Welcome to MS Monthly Report Series. I'm Alex Rae-Grant, Director of this activity and Director of Education at the Mellen Center for Multiple Sclerosis. I'm pleased to introduce Dr. Pat Coyle, Professor and Vice Chair for Clinical Affairs at Stony Brook University Medical Center and Director of the MS Comprehensive Care Center there. Dr. Coyle is extremely well known in the MS community and has participated in clinical trials and research publications in the areas of multiple sclerosis, neuroimmunology, neurological infectious disease, and specifically Lyme disease. She's had multiple leadership positions with the ABPN, the AAN, the ANA, and the National MS Society. In this presentation, Dr. Coyle will talk about switching MS medicines. What do we know, and what do we do? Dr. Coyle.
My name is Dr. Pat Coyle. I'm Professor and Vice Chair and Director of the MS Comprehensive Care Center at Stony Brook University in Stony Brook, Long Island, New York. Welcome, and today we're going to be talking about switching MS medicines. What do we know, and what do we do? We'll start with a case, Alex. This is a 45-year-old postal supervisor with relapsing MS, and he was diagnosed just 8 months ago. You've never seen him before. He has decided to switch doctors, and he's seeing you for the first time. He had presented with a transverse myelitis 8 months ago. His workup showed suggestive MRI lesions involving his brain and brainstem and spinal cord. He also had positive spinal fluid oligoclonal bands and actually met the 2010 diagnostic criteria for relapsing MS. He received 5 days of high-dose steroids but never made a complete recovery from his spinal cord syndrome. He's been on pegylated interferon beta 1A for 6 months, and he chose that because it was the lowest injection frequency agent. Now, during our initial evaluation, when we're taking the history, he's speaking in a monotone. He has very poor eye contact. He voices a concern that some of his injections are quite painful, that he feels worse since he started the medication in the last 6 months. And on exam, we do confirm a mild paraparesis with upgoing toes. And what is your major concern about Alex? A, whether his diagnosis is correct. B, why he switched doctors. C, treatment adherence and compliance. And D, checking vitamin D and B12 levels. And please choose your answer. And I think we're going to come back to the fact that I would have a real worry about treatment adherence and compliance in Alex. But we'll visit back with Alex in a little bit. Well, switching MS medicines, what do we know, what do we do? We'll begin with a background, discuss briefly adverse events, breakthrough activity, some basic switch principles, data from recent studies, and then summarize with future needs. We have multiple disease-modifying therapy options, actually 13 distinct approved agents for relapsing forms of MS with 8 different mechanisms of action, and they fall into 3 categories. We have the first-line injectables, 5 distinct interferon betas and 2 glutathione acetates, 3 oral agents, and 3 intravenous agents that have higher efficacy but also higher risk, and we know that none of them cure MS. Now, we've divided our agents. People talk about first and second line. It's really based on risk-benefit ratio, with the second-line agents perceived as having greater efficacy but somewhat greater risk. Now, we often hear about escalation versus induction therapy. I'd like to define those because people don't always do that. Escalation therapy refers to starting with a first-line, perhaps overall less efficacious but very safe agent, and then you only move to a higher efficacy but greater risk agent if necessary. Induction therapy refers to early use of an immunosuppressant to shut down the immune system of the individual, often with long-lasting effects, and generally that will be followed by an ongoing, perhaps less effective but safer disease-modifying therapy. That's a principle that intellectually is very appealing for use in MS, but it's not applicable to all MS. And quite frankly, we don't know whether that's a good strategy for all MS or should just be reserved for very high-risk MS patients. Now, not all MS patients respond well to their disease-modifying therapy. In fact, 20 to 50% in some series may not do well on the medication that we choose. This is likely magnified by delaying their treatment, by not matching the patient and their initial disease-modifying therapy choice well, and by not identifying poor responders quickly. New concepts in the treatment of relapsing MS emphasize early treatment, close follow-up both clinically and with MRI scan, particularly in the first 2 years after initiating a treatment, and making sure compliance is optimized. And the ideal goal is treat to target. And let's talk about that a bit. If you're going to say, I want to treat to target, you have to have a therapeutic target. You want to know what your goal is. You have to have a way to measure whether you're achieving it or not, and you also obviously have to have available treatment options. And this has not been invented by the rheumatologic disease. Treat to target was used for hypertension and diabetes, but the rheumatologic diseases have really adapted it, and there are a lot of echoes for those of us taking care of MS. In rheumatologic diseases, particularly such as rheumatoid arthritis, RA, treat to target, the goal is remission, no evidence of disease activity, or minimal disease activity. And RA actually has formal treatment guidelines that encourage early therapy, meaning within 3 months of presentation of their RA, or at the latest 6 months. They formally take into account disease activity and prognostic profile. They have sheets that you can fill out. And if they have a lot of disease activity, high disease activity, and poor prognostic profile, it can influence the initial RA therapy. Frequent follow-up every 3 months and switching if they're not doing well. Those are important principles that we could talk about applying to MS. Now, it turns out in the RA sphere, treating to target remission or minimal disease activity, only 7.5% to 9% actually get remission for any length of time. And if you add blood laboratory markers, remission falls to 5 to 6%. So for the most part, in rheumatoid arthritis treat to target, they're talking about minimal disease activity, and I do think it will be similar with MS. Now, in MS, we talk about NEDA, no evidence of disease activity, NEDA, meaning no clinical attacks, no confirmed worsening on the neurological exam, no new MRI lesions, neuroenlarging T2 or contrast lesions. And this fits very nicely with a remission treat-to-target goal. So maybe NEDA can be a theoretic treat-to-target. NEDA has been evaluated in clinical trials as a secondary outcome, and unfortunately, less than 50% of our DMTs will produce NEDA over 2 years. So the majority of MS patients, they can't achieve NEDA with our current therapies. It may be too strenuous for clinical use. In one real-life cohort at Partners in Boston, they longitudinally follow MS patients. This is a cohort of 219. Well, 46% of their MS patients met NEDA at year 1. Only 8% were still meeting it at year 7. There may be some hope. HALT MS is a hematopoietic stem cell autologous bone marrow transplant study where they were able to get NEDA in 75% at 3 years, but that's a very small number. They're obliterating the immune system, and how many will meet NEDA at 5, 7, 10 years? I think it's going to be way less than 75%. There have been refinements proposed for NEDA, adding on a brain atrophy measure, adding a cognitive measure or symptom measure of quality of life, patient-reported outcomes. But NEDA, in my opinion, remains a research goal and only theoretically a goal in clinical practice. Now, we do have some guidelines, and in the United States, in 2014, we had MS Coalition Consensus Paper guidelines that said treating MS with a DMT is indefinite unless you have a suboptimal treatment response as determined by the patient and their physician, intolerable side effects, inadequate adherence, or a better DMT, more appropriate DMT becomes available. Those are your reasons for switching. Moving between the DMTs should only occur for medically appropriate reasons. And when there's evidence of breakthrough clinical and/or MRI activity suggesting a suboptimal response, consider switch, but go to a different mechanism of action agent. Don't stay in the same mechanism of action agent. And the MS Coalition paper actually gave good rationale for why we needed multiple DMT choices, because no single DMT is ideal, and we don't see 80-90% response. So there are very good reasons for having multiple options. It's helpful. So what are the major classes of reasons to switch? Poor adherence, compliance, adverse events, breakthrough disease activity. For poor adherence and compliance, and think back to Alex, be aware of warning signs. Educate the patients. Have them have realistic expectations of the treatment. They're not necessarily going to feel better or be better. Understanding rationale, know the MS damage process, know how to approach side effects to minimize them for quality of life, and always ask neutral, non-threatening questions about missed doses. How many doses have you missed in the last month? Don't make it accusatory at all. And adherence is a major concern, and we've identified risk factors. Depression. Alex was depressed. cognitive deficits? Do they not have a well-grounded perceived benefit risk, quality of life issues, side effects? That was a problem with Alex. Economic burden. A collaborative, proactive, targeted program works best to really maximize adherence compliance to our MS disease-modifying therapies. Now, what are adverse events that might lead to switching? Poor tolerability, an unacceptable change in the patient's risk-benefit ratio if they continue on the treatment, or abnormal laboratory data or clinical complications, which clearly implies ongoing monitoring. Generally, we will be checking with most of our DMTs, the CBC with diff and liver panel. Is the patient symptomatic from the laboratory abnormality? How bad is the abnormality? Is it persistent? For neutralizing antibodies or NAbs, honestly, I think they're only truly relevant for Natalizumab. If you have persistent NAbs to Natalizumab, it's not working, and they're at increased risk for infusion reactions. It's got to be persistent over a couple months, but that would be a reason to stop Natalizumab treatment. Now, when we turn to breakthrough disease activity as a rationale for switching therapy, let's start with clinical. Relapses, premier, prime, number, how often they're occurring, but also the severity of the attack and whether there's recovery. These are important things to measure. Disability, worsening, sustained, confirmed worsening on the neurological exam, cognitive status, and the degree of symptoms and quality of life could all come into a consideration for clinical breakthrough disease activity. When we turn to MRI breakthrough disease activity, and we do monitoring surveillance MRI scans of the brain routinely when we started DMT, the classic are new or enlarging T2 lesions, contrast lesions, or T1 lesions. We should be able to tell those macroscopic disturbances. But that requires a standardized protocol and direct comparison. And when we're doing monitoring brain MRI, there should be a direct comparison with the prior studies. In the future, we may be using volume loss in the brain or the cervical spine and non-conventional imaging techniques to see microscopic injury, but we're not there yet. And a recent consensus recommended that when you start a new DMT, you get a brain MRI 6 months on treatment to have a new baseline, and then repeat it every 1 to 2 years while on the DMT to capture silent MRI breakthrough disease activity. Now let's return to Alex. Remember, we've had a concern about him. We do a current surveillance brain MRI. He's come to us for the first time. It shows 4 new T2 lesions compared to his baseline, which he brought on disc, and one of the lesion enhances. He supposedly was on pegylated interferon beta for the last 6 months, but when you have a heart-to-heart talk and tell him this, he admits he hasn't been taking it in the past 2 months. He also tells us he had a clumsy, numb left hand a month ago for a week, but he attributed it to a pinched nerve and never reported it. So which of the following is an issue for Alex? A, lack of knowledge about MS. B, depression. C, poor communication. D, all of the above. Well, I'd vote for D, all of the above. He didn't recognize a relapse. He didn't communicate it. He really doesn't understand the MS disease process, and certainly depression was a problem. So what are some basic switch principles? The patient needs to be on therapy probably at least 6 months. If we're going to switch, make that washout as short as possible. You have concerns of return of activity when the patient is untreated, and both Fingolimod and Natalizumab in a minority may be associated with increased disease activity on withdrawal, so-called rebound phenomenon. No washout, meaning 0 to 4 weeks between starting the new switch disease-modifying therapy, the new disease-modifying therapy is reasonable when coming off interferon beta, glutathione acetate, and dimethyl fumarate. It's also reasonable to have a 0 to 4 week washout on Fingolimod, so long as you don't have a very significant leukopenia or going to an agent that can perhaps magnify that result. And also for Natalizumab, provided you've done imaging of the brain to screen for occult PML in that 4-week washout period. For teriflunomide, you always want to do the washout, the cholestyramine washout, to bring the blood level less than 0.02 micrograms per ml. The switch should be to a new mechanism of action agent when there's breakthrough activity, and there is really data that an escalation type of therapy works better in this setting. Really pay attention to efficacy when you're switching because of breakthrough activity. So we do have some data. This was a very famous study done in Italy, 394 relapsing patients who were going on interferon beta 1b over a 5-year period. they classified them after starting the interferon beta as a responder at 1 year with regard to whether their MRI scan showed new T2 lesions or not. And the outcome was their EDSS at 5 years and worsening on that. Well, it turns out the more new lesions you saw on that brain MRI, surveillance brain MRI at 1 year, the hazard ratio of developing disability 5 years later went up. If you had 3 or more new lesions, it was close to 30 likelihood of their becoming disabled. It was way outweighing having a clinical attack in the first year, seeing lesion activity, and the more new lesions, the more likely they were to develop disability. So this really endorsed the concept of MRI breakthrough activity on an interferon beta early on in the first year being very meaningful. And they actually had a very good review article in Neurology last year that reviewed brain MRI outcomes with a whole host of interferon betas, the literature up to date. And they said that the conclusions were that early MRI activity on interferon beta predicted worse later outcomes on interferon beta, that the predictive ability was greater for seeing breakthrough contrast lesions than new or enlarging T2 lesions, and greater the more new lesions you saw. And they marked poor response or non-responders over 2 years in, on average, 24% of MS patients started on interferon beta, ranging from as low as 3% to as high as 49%. 2 or more new T2 lesions or a new contrast lesion showed increased risk for subsequent relapses and disability. And they wound up, after reviewing all the data, recommending a monitoring surveillance MRI at 6 to 12 months. And if you had a poor MRI responder on interferon beta, they said switch them. Even if you didn't have clinical attacks and clinical worsening, go ahead and switch them. There was enough data to support that. Can we apply this to other agents? Well, we have to be a little bit careful. This was a prospective longitudinal study of 151 relapsing patients on glatiramer acetate, analyzed at year 1 to predict subsequent activity in the next 2 years. And here, seeing breakthrough MRI activity, that was not predictive of disability, unlike the interferon beta studies. If you had a clinical issue, a relapse, plus MRI activity, that predicted poorer outcome. But here we couldn't say, let's say, seeing an enhancing lesion at 1 year on GA predicted the same thing that seeing an enhancing lesion on interferon beta did. And they are very different mechanisms of action. GA actually doesn't work at the blood-brain barrier. This is another big switch study from Natalizumab to Fingolimod, a multi-center, 36-center French cohort, 333 patients. On average, they'd had 31 doses of Natalizumab. They had various washouts, 27% relapsed during washout, and their take-home was that if you're coming off Natalizumab to go on a new drug, your washout should be less than 12 weeks. You were significantly less likely to have a relapse if it was short, and if you had a washout longer than 12 weeks, you were likely to have a clinical attack breakthrough. And your baseline disease activity, was it a real active patient before they went on Natalizumab? They were more likely to have breakthrough activity. So it really said pay attention to the washout. Now, there have been recently, this past year, 3 MSBase global registry switching studies. Now, understand this is collected from MS centers throughout the world, and they really looked at, switches. They're non-randomized, but they tried to match the patients through propensity scoring. So in one of these, they looked at MS patients that had had a breakthrough attack on interferon beta or GA, and they were switched to either Natalizumab or another interferon beta or GA, and they tried to match them up by propensity scoring. Well, the Natalizumab switchers did better on relapse and disability. Another study from the MSBase looked at breakthrough on interferon beta or GA, switched to Fingolimod or another interferon beta and GA, again matched, and they did better if they were switched to Fingolimod than if they were kept within the interferon betas. And then we had another MSBase study, these are several hundred patients, where they had a relapse or had broken through on interferon beta or GA, and they were switched now to Natalizumab or Fingolimod, and they tried to kind of make them comparable by the propensity scoring. And here the Natalizumab switchers did better than the Fingolimod. Now, obviously, these are not randomized control patients, but very interesting real-life data with propensity score matching. So let's return to Alex. After discussion, a decision is made to go on an oral therapy. He wasn't taking his interferon beta. He doesn't like injections. After completing screening, he starts Fingolimod. He's also seeing a therapist. It's notedly improved his mood. He has a monitoring surveillance brain MRI 6 months on Fingolimod, and he has 3 new lesions and 2 are enhancing, even though his exam is stable, and he's reporting that he's feeling well. What is the first thing that should be done? A, change his DMT. B, treat with several days of high-dose steroids. C, don't do anything. 6 months is too early to judge. D, check adherence compliance. Well, he was not adherent compliant to his first medication. That would be the first thing that I would check. But he denies missing any doses of Fingolimod and states he's never felt better. What will you do at this point? A, check a JC virus antibody for a potential switch. B, plan to do his next MRI scan in 3 months. C, switch to a different oral therapy. D, stick with Fingolimod. There isn't a right answer here, and granted this is not an interferon beta, but I'm worried about Alex. And I think for me right now, probably this is too much disease activity. He's had a lot of MRI disease activity, in my opinion. So he's JC virus antibody negative, and the plan now is to discontinue his Fingolimod, even though it's only been on it 6 months, but it takes 2 months to be operational, and start Natalizumab. How long should his washout be? A, no washout. B, no washout unless he's lymphopenic. C, 1 month washout. D, 3 months washout. So vote. Well, I'd say no washout, meaning 0 to 4 weeks, unless he's lymphopenic. That would be the only thing that would concern me. So to summarize and talk about our future needs in switching MS patients, the first 6 to 24 months on a disease-modifying therapy are important to identify poor responders, and we need to follow patients closely, both clinically and with monitoring surveillance brain MRIs. Patients who are not doing well should be assessed first for adherence compliance and make sure there's optimized management of any bothersome side effects. Unacceptable breakthrough activity should result in a switch to a different mechanism of action, disease-modifying therapy, with a minimal to no washout period. And consider efficacy. Efficacy becomes important if there's been breakthrough activity. Data from the interferon betas indicates 1 or more contrast lesions or 2 or more T2 lesions is probably unacceptable in the first 6 to 12 months on treatment. It's unclear if that can be directly applied to other DMT classes. NEDA we talk about a lot, but it's probably too stringent. It's a great goal clinically, but probably too stringent to rigidly hold on to currently. For MRI criteria alone, except for interferon beta, I generally will require 2 unacceptable MRI scans. Now, I didn't do it in Alex, but I have other reasons to be concerned about Alex. Future needs, we need biomarkers to predict the best mechanism of action, DMT, for the individual patient, to provide rapid response measures with regard to how they're responding. This may involve genes upregulated and downregulated or immune system changes. So we can tell a poor responder and get them off the treatment quickly. We need to identify meaningful MRI activity to dictate change, and we need to identify individual safety profile stratifications. Thank you very much.
Thanks, Dr. Coyle, for your cogent comments on this topic. It was quite helpful to hear your perspectives on reasons for switching, which can vary from individual to individual and be as simple as GI upset or as complex as risk-benefit analysis. You helped us focus on the concept of treating to target, trying to achieve reduced or no evident disease activity, and using this principle to guide when and who to change medicines in. You confirmed that adherence is a major issue in the MS DMT care field and guide us in how we can optimize care for this complex population.